Hi, I'm Dr. Robert Ang from the Philippines, and I'm a practicing refractive surgeon there. I've been using ICLs for the past 13 years. So I started with the version with no aquaport, and now I'm all in with the EVO and EVO Plus. Just like most refractive surgeons, we have patients coming in with high refractive errors, -9, -12, -15. And I didn't really want to go into clear lens exchange because I think there's a lot of risk, especially on the retina. So having a phakic IOL option really completes your refractive practice. So I started with ICL back then. First, the aquaport has made complications almost nil. So safety is a general consideration, but more importantly, I like the predictability and accuracy of outcomes. It's rarely the case where you put something in and 99% of the time you will be on target in terms of refraction. So that has encouraged me to keep using the ICL more. So at the beginning, I was using it only exclusively on high myopes and those disqualified from refractive surgery like lasers. But now I moved down. So my protocol now is everybody -5 and above. That is the first choice, and most of the time the only choice I offer. So I have patients who unfortunately have suspicious topographies and they are low myopes, below -5. So I offer this option to them because I think it's safe for them to undergo ICL and not have to touch the cornea at all. Actually, more and more patients are having treatments with low myopia. So, for example, in my practice, I have a lot of patients who are straight out of high school and they want to go into pilot school in the Philippines. So I tell them that laser surgery, corneal surgeries may cause a lot of photic phenomena that may affect their future job. So the ICL has less of this glare, halo, starburst at night. They offer best contrast sensitivity testing. So I think it's fit for them to have an ICL because of their visual requirements. So this is definitely a good option for low myopes too. The EVO ICL is a phakic IOL which you insert in the eye, and I emphasize to the patients that I don't remove any part of their eye at all. So there's no tissue removal, unlike other options. So that in itself is a big advantage. Number two is it's a reversible treatment, and I cannot think of any other refractive treatment that is fully reversible or removable in that case. So I think these two options give patients comfort that safety is a big consideration when I make this recommendation. Aside from all the laser options in refractive surgery, they should also learn how to use a phakic IOL like ICL. And it's because us, the senior ophthalmologists, continue to use the ICL long after we've started. So it's a testament to how good the outcomes is and how happy we make the patients and how good it has been to improve our practices. So that in itself should give them the encouragement that this is good not only for their practice but for the patients as well. Another advice I would give the young doctors is please stick to the guidelines as much as possible in terms of screening patients and in terms of surgery protocol. That way, you're assured that most of the time or almost all the time, you will have the best possible outcomes and you avoid problems and complications because that will continue to encourage you to do more and for patients to come to you. So I tell the patients, we've screened your eye and you're qualified for the following refractive treatments. So laser surgery can do this, but it can also remove tissue, cause these other disturbances. I also tell them that ICL can offer this, but also the downside. So to have a balanced point of view, you give the good and the drawbacks. And you tell the patients that if you were to choose, you choose based on what you feel is best for you. And these are the outcomes I get, and based on that, they make the decision. Right now, I noticed that most of the myopia that comes to me in the young people are above -5. 8-10 years ago, they're like mean of -2, -3. So this trend of increasing myopia is definitely there. Of course, we want to offer the least side effects to the patient and probably as good an option to them. The EVO ICL, I think, completes everybody's refractive portfolio. If you don't have a phakic IOL in your portfolio, you're not a complete refractive surgeon, and your center does not offer a complete offering. So I think EVO plus ICL and all of those phakic IOLs will definitely be beneficial in terms of making sure that you have a balanced point of view and you offer all options to the patients.